And again, we're back to the debate format. So we have a surgical debate that will be run by Dr. Bill Chapman from the WashU St. Louis. Bill is the director of the surgery, general surgery and chief of transplant, and a very important key figure on the habitability scene with the HPBA and other formats as well. And the other speaker is Dr. Mike Choti from University of Texas Southwestern. Again, well known in the field and the ex-chair of the NCI task force for habitability. We worked together for quite a while, and it has been great transition between both of us. Thanks, Mike, for that. And so the discussion is about the extrahepatic cholangiocarcinoma. This is specific because the question is pertinent in that regard. Should or should not be transplanted. And so Bill, as a transplant surgeon, is going to say should be transplanted, and Mike is going to say should be resected, and then we'll give 5 minutes for Bill to rebuttal. So Bill, you can start.
Thank you very much. I'd like to thank Dr. Abu Alpha, Dr. Kim, Stacy Lindsay, and others on the planning committee for inviting me to participate. This is a great meeting. It's great to see the level of energy focused on what really is a very difficult disease. I don't have to tell anybody in this room, but certainly for surgeons, this is a pretty difficult disease to think about managing. So this is scheduled as a debate. I will tell you at the outset, it's kind of a hard topic to debate because this is not really an either-or proposition. They're candidates for each strategy. I will highlight some of the data that's available, some of the limitations for transplantation, and what I think are still a lot of limitations for standard surgical resection. Let's see. Before I begin, I have a couple of disclosures. I'm one of several founders of an image-guided liver surgery technology that I'm not going to discuss today. Likewise, I'm on the advisory board for Novartis, and we won't touch on any of those areas. I think there are a number of questions to think about in terms of liver transplantation and resection for patients that have cholangiocarcinoma. And I thought I would bring up a few of them at the beginning. There are some of these that there's some data available, and some of these questions we can't answer right now. But I think a big question in the field is how effective is liver transplantation for de novo as opposed to PSC-associated cholangiocarcinoma, and how does this compare with hepatic resection? What are some of the limitations of transplantation? I think a big question, a tricky question, is how does transplantation stack up compared to resection in patients with resectable cholangiocarcinoma? So today we think about transplantation for patients with unresectable disease. What about patients that have resectable disease? How favorable have the results that we've seen today for transplantation been influenced by transplantation in patients that potentially don't have cholangiocarcinoma? In other words, advanced PSC, and maybe they never had cholangiocarcinoma. What are the results for liver transplantation at non-Mayo centers? There is some data available. And what about for intrahepatic cholangiocarcinoma? So I think, as everyone here knows, cholangiocarcinoma is relatively uncommon. There are about 3,000 cases a year, and I'd put that against some other common HPV diseases we see. Hepatocellular carcinoma, there are about 30,000 cases a year. I think this disease in some ways is similar to Pancreas cancer, difficult disease to treat. We treat it surgically. The outcomes are not so great. There are 50,000 cases of pancreas cancer a year. So we're in a pretty niche area, which makes it difficult sometimes to have studies and strategies and data to help inform decisions about therapy. So about 60% of cholangiocarcinoma extrahepatically is in the HILAR region. That's really what we're going to focus on today. 30% are said to arise in the mid duct or distal duct, and about 6 to 10% are intrahepatic in location. I'll make a few comments about intrahepatic cholangiocarcinoma also. So historically, only about 50% of explored patients have been able to undergo resection. That's probably only about 20% today with current imaging. PSC, as I've mentioned already, is known to be an associated risk factor, and this can complicate treatment decisions, and it plays in a major way for patients with thought to have cholangiocarcinoma. So we're really talking about tumors in the upper duct here as far as transplantation is concerned. This is a type of tumor we're talking about that wouldn't be considered. Can you go back one slide? Considered for resection, where there's second-order duct involvement on a bilateral basis. So this is characterized as a bismuth 4 tumor. This is a staging system commonly used where type 4 have localized disease, small tumors, but otherwise are not candidates for standard resection. All right, so these tumors are felt to be slowly progressive, although rapid growth can occur. Hematogenous metastases are uncommon, but local nodal metastases are present in 30 to 40% of patients, and this is a challenge when thinking about transplantation. Direct invasion of the liver and perihepatic structures are common, and invasive spread is often perineural and subepithelial, with at least 20% of patients having R1 disease at resection. So patients predicted to have a margin-negative resection. In fact, when the pathology finally comes back, it's at least 20%. What about liver transplantation? So the early results for liver transplantation with clinically detectable disease were dismal. So through the 70s, 80s, early 90s, the outcomes results were not good, mainly because of aggressive recurrences, and almost all centers abandoned considering transplantation. Now, this was a few centers, including Nebraska and the Mayo Rochester, continued protocol-based therapy, and that has led to successes, and the Mayo Group's really been one of the main leaders in this area. And this progressed to the point that UNOS now recognizes this as an acceptable indication under certain conditions. So this is patients receive exception priority points if the patient is being evaluated under a protocol with chemoradiation, is neoadjuvant therapy as a standard with no evidence of extrahepatic disease, including lymph node sampling. All right, so I want to show you some data. This is one of the early reports from Julie Heimbeck and the Mayo Group showing what really were excellent results for an otherwise pretty dismal disease. 56 patients were considered. There was about a 50% dropout rate. Some who never made it through chemo radiation, about a third who were found to have metastatic disease. But of the remaining 50%, there was who went on to transplant, 82%, really exceptional 5-year survival rate. This is a report from Greg Gorse a couple of years later showing their excellent result after transplantation. Well, this certainly caught our eye and some other centers, and we started in 2005 an IRB protocol that's pretty similar to the Mayo protocol that had been put in place. We modified this a little bit. Patients got induction chemotherapy. We use conformal external beam radiation. We don't use brachytherapy. It's a little more convenient from a patient point of view. Otherwise, a pretty similar protocol to what Mayo has utilized. There are a few points I would bring up about this approach. One is establishing a tissue diagnosis can be quite difficult. These tumors are not easy to access, and transperitoneal biopsies are a really bad idea. So patients, you need either positive biopsy, positive FISH, or CA19-9 greater than 100. And this is a little bit of a nonspecific value, but this is what's considered acceptable for inclusion criteria. Good performance status, no metastatic disease, ages 18 to 70, otherwise pretty standard protocol. What about FISH? So FISH is now available on a commercial basis. The cytologist can save cells at the time of brushings, and there's a strong positive correlation between a positive FISH and the presence of HILAR adenocarcinoma in the right clinical setting. Exclusion criteria are, I would say, pretty standard: extrahepatic disease, intrahepatic metastatic disease, uncontrolled sepsis. I think the two things I would point out, percutaneous or EUS-directed biopsies are considered a relative contraindication. And this is a big problem because most individuals evaluating patients for the potential of cholangiocarcinoma at the evaluation are not thinking liver transplantation. They're thinking diagnosis. So to go down this pathway, they're not really even assessing patients for the potential of resectability. They perform a endoscopic FNA, and most don't even know that's a contraindication to be considered for a transplant. Now, we will consider patients for our protocol, but we're pretty concerned about it. Some centers, I don't think, Mayo Rochester, I don't think patients, I think you can't get in the door if you've had a transperitoneal biopsy. And the data, really support the view that that's a pretty negative approach. So I do want to point that out. I'm pretty concerned about patients that have percutaneous catheters for the same reason. They're transperitoneal, they're brushing up against a tumor. You got to be really thoughtful about what therapies are done before decisions are made about whether a patient's a resection or a transplant candidate. So there are a lot of protocol limitations, and one is physician awareness. A lot of physicians don't even know this is an option. There are access issues. Patients have to get through neoadjuvant chemotherapy. Funding can be an issue. Insurance companies often deny this therapy. And then the obvious issue of wait list limitations with limited organs for transplant can be an issue. All right, so let's talk about the approach and a little bit of the results. So just for those of you not connected with the transplant field, the way this works, you meet the protocol, you go through chemoradiation, you get approved as part of a standard protocol, you get 22 MELD points. So in most parts of the country, this is model for end-stage liver disease, most parts of the country, transplants occur, cadaveric transplants, at around 25 to 28 to 30 or higher MELD score. So you start at 22, every 3 months you get a MELD score upgrade. there is going to be probably minimum 6-month wait, and in some parts of the country, higher. What about PSC? This is a pretty tricky area to know. Patients that have fibrosing strictures in their liver, the ability to distinguish HILAR cholangio in that setting can be quite difficult. What about patients undetected that have unsuspected cholangio? No neoadjuvant therapy. Well, this is one report from a Canadian series. The results are really quite dismal, with 20% long-term survival. So if you're going to consider it, patients really have to have neoadjuvant therapy. You need to detect the tumors up front. All right, so I want to show you a few little bit of data on outcomes results. These are results some data Chuck Rosen gave me from, shared with me from the Mayo Rochester series a couple of years ago. So in their series, at least at that time, there were 196 patients that had been enrolled from the beginning through 2010. 172 made it to staging operation, and 126 had been transplanted. So their dropout rate had dropped over time. It hasn't remained at 50%. It's improved over time. When you look at the overall results, these are their results looking at on an intention to treat basis. So 5-year survivals, 56%. All comers, including dropouts, including those who never made it to transplant. When you look at, when you separate those out between patients with PSC and their de novo cases, and here you can see the weighting of PSC, very predominantly a PSC cohort. 63% 5-year survival compared to not as good, 44% for de novos. If you looked at the results only in those who made it to transplant, really quite excellent, 74% at 5 years. When you separated those results based on whether patients had PSC, 80%, significantly better than 64% for the de novo group. What about the possibility that some of these patients maybe never had cholangio at all? 82%, 82% for patients who never had confirmed pathology compared to 66% for those that had tissue diagnosis, either on the front end, brushing, or in the explant specimen, or developed metastatic disease later. All right. Recently, there's a multi-center study I want to show you the results about, looking at, well, what about the non-Mayo centers? How does this work when this is done on a broader scale? So 50 centers were surveyed, 12 centers met inclusion, which was basically at least 3 transplants performed under this protocol, 287 patients identified. The results are pretty similar. So 5-year survival on an intention to treat basis, 53%, 42% at 10 years. On a post-transplant basis, in other words, just those patients who were transplanted, 5-year survival, 65%. This is across a broad group of centers now using transplant. If you looked at, if centers stuck to the strict inclusion criteria, 3-centimeter tumor, standard therapy, standard staging, didn't expand their criteria, 5-year survival, 82%, quite excellent. Centers that began to expand their criteria, taking, including transperitoneal biopsy, larger tumors, more borderline indications, results are not so good, 40%. And if you just looked at tumor size, 3 centimeters or smaller, 69% 5-year survival compared to 32% those greater than 3 centimeters. All right. That gives you a little bit of a snapshot for transplant. Let me just touch briefly on where we are with resection. I know Dr. Choti is going to talk more about this. One of the best series looking at resectable HILAR cholangio is from Al Hemming, published a little more than 10 years ago, about a 40% 5-year survival. And that's about as good as we can do in this disease. Patients who have negative margins resected, it's actually a little better, almost 50%. But here, this shows a more recent report. This is from the Sloan Kettering group. And the 5-year survival, 35%, 10-year survival, 20%. That's with margin negative patients. Margin positive patients, they're no long-term survivors. All right, I'm going to touch briefly on, well, what about intrahepatic cholangio? We've heard a little bit about that this morning. This is a typical case, mass-forming tumor in the liver. The results are in that situation, most people would approach with standard surgical resection. You want to think about transplantation in certain cases. This would be an example. Well, this is a very advanced stage tumor that can't be resected. These patients are never going to be considered for transplantation. Aggressive surgical approaches can work in some of these patients. Well, what about data for larger series? These show results that are really pretty similar for HILAR tumors. So without lymph node metastasis, 5-year survival of just over 20%. Solitary tumor, just over 20%. Not very favorable. What about liver transplantation in these patients? Generally, this is considered a contraindication for transplantation because of recurrence risks. There are some reports, and we've begun to reconsider patients on a highly selected basis. This is a report, 28 patients looking at transplantation. These are all patients with underlying chronic liver disease. And patients who had a single tumor under 2 centimeters in size fared pretty well compared to about a 40% long-term survival in those with larger tumors. Finally, I want to touch just briefly on a new strategy we've been using for unresectable or borderline resectable intrahepatic cholangios, and that's using pump chemotherapy. I think there was some discussion of this yesterday. This is really taken off from work done mainly in colorectal cancer. And the idea is that use of a pump with chemo directed in a hepatic arterial source could achieve more favorable results. The Sloan Kettering group published a series a few years ago in a phase 2 study that looked pretty favorable. We started our IRB protocol following that study. We've enrolled over 20 patients now. And the idea here is you place a pump in the gastroduodenal artery to provide hepatic-directed therapy. We've progressed from pump only to pump plus gem to now pump plus gem-cis and seen pretty favorable results. So we're in cohort C. Of our first 20 patients, we've downstaged 4 patients to resection. Here's an example. This is a patient with a very locally advanced tumor involving all hepatic veins. This patient, after 17 months of treatment, had a marked downstaging, and we went on to resect this patient that included caval resection and replacement of the diaphragm. This patient lived 2 more years and died of lung metastases. So it's just a consideration in as therapy in a selected patient group. So I'd conclude that liver transplantation is a effective treatment for carefully selected patients, but only under a neoadjuvant chemoradiation protocol. EUS-guided biopsies and operative expiration should be avoided in patients being considered for transplant. Results appear to be more favorable for patients with PSC and cholangio. Standard surgical resection, I have to say, remains the best option for the majority of patients. Having said that, about at least 20% of resected patients are going to have positive margins. Outcomes for transplantation for cholangio on a broader scale appear to be favorable. Strategies for management of advanced intrahepatic cholangio are still in evolution. I'm going to stop there, and we'll open this up for questions after Dr. Choti's discussion.
Well, I also would like to thank the organizers. A terrific meeting, a terrific cause. I'm glad to be part of the organization and to be part of the program today. I appreciate Dr. Chapman's terrific review of the field, but remember, this is a debate, so I think even his conclusions, he already conceded that I probably can save a lot of time, that he even concluded that in resectable patients, resection should be the treatment of choice. We heard about intrahepatic cholangiocarcinoma, we heard about in unresectable patients, but really the focus of the debate was resection versus transplant in patients with extrahepatic cholangiocarcinoma, and so we'll focus on that discussion. So let's frame the question. Here's a patient, resectable HILAR cholangiocarcinoma. 57-year-old nurse presents with 2-week history of jaundice, elevated bilirubin, CA19-9 is 14. You can see here that there's a stricture. This is a bismuth class 1 or 2, resectable by definition. So the question is, do we offer resection or do we offer transplantation in this resectable patient? That's really the focus of the debate today. And as you heard a little bit, the anatomy, we're focusing on extrahepatic cholangiocarcinoma for this discussion. And in fact, the distal cholangiocarcinomas are really, those are not what we're talking about. Those are not candidates for transplantation. And neither is the intrahepatic cholangiocarcinoma, but we're focusing on extrahepatic, the peri-HILAR, or a Klatskin type tumor. What is the best option in resectable patients? In fact, interestingly, you've seen some numbers that 50% or more are HILAR cholangiocarcinoma, but really the landscape is changing. We're seeing more intrahepatic cholangiocarcinoma. In fact, probably the incidence of HILAR cholangiocarcinoma relative to the other ones are in fact decreasing. These are data, as I'm sure you've seen, from 2004, showing a dramatic increase in the incidence of intrahepatic cholangiocarcinoma compared to that of extrahepatic. But it's still, of course, as you heard, a significant problem. And you heard a little bit about the classification, the bismuth-Corlett classification, and this really, in part, defines resectability, the topic of this discussion. And so patients, I don't know, does this have a pointer? Yeah. Oh, the star. So you can see the different classes depending on the location. So the tumors that extend up into the biliary tree then become unresectable. So this is the group of patients we're talking about, the resectable patients with bismuth-Corlett class 1 or 2. The borderlines, the extension into at least one, some would consider this potentially resectable, borderline, and this is clearly the unresectable group. A lot of the data you saw were in patients with clearly unresectable disease. There's some level of controversy in the borderline cases because those patients are often unresectable, but the focus is resection or transplant, largely in the resectable category. How do we define resectable aside from just the extent up the secondary biliary radicals? Of course, in a patient undergoing resection, they need an adequate, they can't have medical contraindications or liver disease that would preclude major hepatic resection. It's often the tumor-related factors that are the most challenging. So it's really assessment of the extent of disease. If it's below the bifurcation or confined to one side, either vascular or biliary-wise, then those patients are potentially resectable. But you can see either if the tumor extends up both sides, we just talked about the bismuth classification 4, or involvement of the ducts on one side and of the vessels on the other side. So encasement or occlusion of the main portal vein, unilateral extension of the bile ducts on one side, but vascular involvement of the other side, or atrophy of one hemiliver with ducts involved in this. So those are unresectable situations. And then typically patients with extensive node positive disease or distant metastatic disease. But even patients with microscopic node positive disease or even N1 disease, that's not an absolute contraindication. So when we compare resection to transplant, one needs to think about the differences in eligibility between transplant and resection. As you heard, it is a challenge determining resectability. We're better now with imaging, including MRI and MRCP, to try to assess these parameters that I've told you that determine resectability, but often it is a challenge, and that is, in fact, one of the concerns here is that it's not uncommon that the patient may be thought to have resectable disease, but in fact are unresectable. Improved imaging, including MRI and MRCP, have allowed us to more carefully determine whether a patient is resectable or not, minimizing the risk, if you will, of finding positive margin disease at the time of planned liver resection. And as you've seen, this is an example of a classic extended right hepatectomy. This is the remnant left hemiliver, sometimes with a caudate lobe resection or not. And this is a Roux-en-Y biliary reconstruction, a limb of intestine, anastomose of the biliary tree. So that's what and of course the remnant liver will then regenerate hypertrophy following the resection. What are the results of resection? Well, it a little bit depends on the series you look at. And clearly there's been a trend. If you look at from the historic series, including from Johns Hopkins decades ago, where the survival rate was dismal, it was really often associated with a failure to do a sufficiently wide resection, including a concomitant liver resection. In the more modern series, where there's the margin positivity rate is considerably higher, major resections included in all, and 5-year survival rates, you can see, have continued to climb up to the range of typically 40%, 30 to 50%, depending on the series, 5-year survival rates after resection of HILAR cholangiocarcinoma. Still not perfect. Still, we haven't demonstrated the efficacy of adjuvant or neoadjuvant therapy in the resectable patients, but certainly these are the outcomes. In fact, some series, this is the series from Berlin from Professor Neuhaus, recommending concomitant portal vein resection. Remember, the portal vein is immediately adjacent to the bifurcation, and so one have argued that it's not really a wide resection without inclusion of the portal vein. And this is the recent series published demonstrating, you can see with the HILAR en bloc resection demonstrating 5-year survival rates in this small series of about 50%. So clearly, hepatic resection, when resectable and successfully resected, in good hands, and demonstrate that we can see long-term survivorship in the range of 40 to 50%. Part of the argument for liver transplantation is that, in fact, HILAR cholangiocarcinoma typically often will recur locally. So if you look at these data compared to gallbladder cancer, where often it's a systemic disease, the pattern of recurrence is often distant disease. 2/3 of the cases, the recurrence is local. Now, this is sometimes nodal recurrence, but it's not uncommon to have local recurrence. So this has prompted the enthusiasm for considering an even wider resection, transplant, in the case of HILAR cholangiocarcinoma. And in fact, these are some initial results. There was an initial level of enthusiasm. It certainly felt to make sense. As I mentioned, local recurrence. It certainly achieves wide negative margins. But in fact, the data, as you heard, is really not great for transplant alone for cholangiocarcinoma, even for early stage. You could see in the Cincinnati Transplant Registry, 28% 5-year survival, 84% of the recurrences occurred quickly. Half, interestingly, were in the allograft, in the transplanted allograft, and they found in this series no benefit to adjuvant therapy. Other reported series, including this small series comparing outcomes of transplant following with no malignancy, hepatocellular carcinoma, even still with some controversy, compared to HILAR cholangiocarcinoma, outcomes significantly worse. So at least the conclusion is transplant alone should not be recommended for cholangiocarcinoma. And this prompted the Mayo Clinic, Nebraska, and others to consider a selection strategy or an aggressive neoadjuvant approach that you've heard about. And this is the Mayo Clinic regimen, as you've heard about, which includes external beam, brachytherapy, chemotherapy, no biopsies, very strict exclusion and inclusion criteria, laparoscopy or laparotomy to rule out and biopsy, and if any lymph nodes are negative, then those patients are out. So the eligibility, early stage, the setting of PSC, or anatomically deemed unresectable. So a lot of the series that Dr. Chapman showed were in patients who had unresectable disease. As we mentioned, prior surgical intervention contraindicated. They all undergo staging resection, and even microscopic node positive are excluded in this series, so highly selected group. And as you heard, these are data. In fact, here, of course, Dr. Chapman is one of the authors in the paper looking at transplant after neoadjuvant therapy. Again, a similar regimen as he's reported in this 12 series, relatively high dropout rate, 25%. 2/3 have PSC in this group. Many did not have proven cancer, so clearly we can already see some biases that favor outcomes. And in this series, you can see here, looking at even the PSC and the non-PSC, the outcomes in this series, published in 2012, with about a 50% in a highly selected group of non-PSC patients, about 50% 5-year survival rate, similar to that of resection. There are other problems with a transplant approach. Most patients, as I mentioned, they drop out after the abdominal exploration. So all these patients undergo a very rigorous protocol, including fairly rigorous neoadjuvant therapy, only to find they're not candidates. And unless we show there's benefit to this form of systemic and regional therapy as a destination therapy, then these patients are subjected to relatively toxic therapy with a significant dropout rate. Patients don't undergo transplant. The reported higher complication rate, long-term complication rates in these series compared to that of those not in the regimen, higher vascular complications, and so this may be associated, may even be higher in centers if this is pushed out to centers with less experience. One argument is this may in large part be all from selection. These are highly scrutinized with pre-evaluation. Duration of neoadjuvant therapy selects out the group of patients. A significant number drop out. And so comparison to resection, which is done up front, includes node positive, includes margin positive in some series. It's comparing apples and oranges. And as you've heard, in the Mayo series, only half the patients had biopsy-proven cancer, and of these, only 40% had any evidence in the explant. So of those that did not have biopsy-proven, so there's the concern is that there's a significant dilution of patients in whom they may have never even had cancer in the first place, included in this series. And of course, the inclusion of PSC. Sclerosing cholangitis is a relatively uncommon cause of HILAR cholangiocarcinoma, and yet makes up 2/3 of the series in many of these transplant series. So it's, in fact, 90% of HILAR cholangiocarcinomas are non-PSC, are de novo. So this is really what we're trying to address here. So in fact, we've never had a randomized trial comparing the two, but the Mayo Clinic, in fact, recently published a report comparing, as best as possible in their experience, resection versus transplant. This was published just last year. You can see a single retrospective cohort, single center, compared neoadjuvant plus transplant compared to resection in the same institution. These are the results. If you take all comers, resection versus transplant, somewhat statistically significantly better for transplant than resection in this group. You can see the numbers here, resection versus transplant. If one looks at intent to treat, then you can see the differences are significantly less in this situation. So if you look at intention to treat rather than comparing those patients that underwent transplantation. And if you look at just those patients, like the transplant patients, margin negative, node negative patients, no difference in outcome between resection and transplantation at the Mayo Clinic. The final problem is really the ethical issues. Here we're talking about in resectable patients with cholangiocarcinoma, should they be offered transplant over resection? Unfortunately, we still have a big problem with a waiting list on transplant. It's rising relative to the number of organs available. So one can really challenge the question, is it really even ethical to be transplanting patients not only with cholangiocarcinoma, but with resectable cholangiocarcinoma? I think it's really a challenging question to offer transplant in patients with resectable HILAR cholangiocarcinoma. And so what are some of the questions that remain? We still have a lot of answers, unanswered questions. For example, what is the role of neoadjuvant therapy in the PSC patients? How much is the neoadjuvant therapy really contributing to those patients? What is the role of neoadjuvant therapy and transplantation in the borderline patients where arguably the margin positivity rate is probably somewhat higher than in the BC class 1 and 2 patients, and so perhaps there may be a selected role in the borderline unresectable patients. We still don't have a good handle on what the optimal neoadjuvant strategy is. These are just best guesses, if you will. And one still also needs to ask the question about neoadjuvant therapy in the resectable patient or the patients undergoing resection. And if we had aggressive neoadjuvant approaches, both for selection and for improved treatment of micrometastatic systemic disease, we may see outstanding outcomes in patients who undergo liver resection for HILAR cholangiocarcinoma. So in fact, if you look at Mayo Clinic, the leader in pushing transplantation for HILAR cholangiocarcinoma, this series, in fact, their conclusions are patients with resectable de novo HILAR cholangiocarcinoma should be treated with resection, because there is no evidence that they would fare better than with liver transplant. So conclusions from Mayo Clinic, that certainly makes my argument on the debate side easier. Certainly there may be a role for liver transplant in highly selected patients with unresectable disease. There may be a role in patients with PSC for transplant. We certainly need better clinical trials and biomarkers to identify which patients may derive actually a benefit from transplant. But currently, based on the evidence we have, it's pretty clear in a patient with resectable HILAR cholangiocarcinoma, you must resect. Thank you very much for your time.
Well, why don't we open this up for questions and discussion? I think what I would say to Mike is this is a very tricky area. And I think unresectable to me is the bismuth 4. Second-order duct involvement bilaterally or vascular involvement precluding effective extended liver resection for a negative margin. Now, Mike includes the threes, the either right-sided predominant, left-sided predominant, and calls them borderline. Well, that's really the group we're talking about. And, a lot of this is more theoretical than real, but the theoretical is, what if you're a borderline patient? And all the surgeons in the room who treat these patients have dealt with this. We can say imaging is better. Yes, imaging is better. But at the end of the day, we have a quarter of our patients that we say going into the case, we're going to have a margin negative resection, and they have a positive margin. And when they have a positive margin, you're done. There's no going back. You can't say, okay, now I'm going to think about a liver transplant. It's not an option. And that's the group, to me, that this is really tricky. So we're not doing so good at our preoperative prediction, or let's just say the technology doesn't allow us to do so well. And I think that's a tricky group.
Robin was up first.
Dr. Kim.
So I think there's, just like you said, Dr. Chapman, there's really microphone, so okay, but then they can't see. Can I just close that? So I don't think there's a debate about when we resect, but like you said, that group 3 is how can you ensure that you will get negative margins? Because there's no doubt if you have R1 resection because you couldn't go deep enough into the hilum, you're going to get deep enough with a liver transplant. So, I mean, that's the question: is how do you select that third group who are borderline resectable, but do it in a way that doesn't preclude transplantation? I think that's going to be. Do you just assume that or do you just predict that you're going to get positive margins, R1 resection, and then go to transplant, or do you hope that you'll get the R0 resection? However, if you're wrong and you've precluded the ultimate, taking the whole liver. I think that's number one. And then number two is, we at the University of Utah, we have a series of these patients who we've transplanted, and I find the hardest thing as a surgeon is to do the transplant like 3 or 4 months out of radiation. And then, heaven forbid, if you have to retransplant, like we've done on a number of occasions, that's tougher. And to that end, for Dr. Chapman, where is the role of living donor liver transplant to be able to control the timing of the resection, the transplantation after neoadjuvant chemotherapy?
Well, those are great questions. I think one, as far as predicting that you're going to have a negative margin, we need improved upfront diagnostic capabilities. So, subepithelial extension is pretty tough to say. It's pretty tough to predict. And I think you have to size up on the front end. Okay, well, what about in the select patients that have distal duct involvement? Are you going to perform Whipple resection? That is certainly an acceptable consideration, but you better have a pretty fit patient. You're going to take on a lot of extra potential perioperative risk, Whipple plus transplant, or extended right resection plus Whipple. I think as far as your second question goes, that's a tricky question too. You can say living donation, use of living donation does help with timing, and I think that is a benefit. Patient has to have a suitable live donor. You can't forget you're putting somebody else at some risk. There are generally no extra vessels, so if you're going to use conduits to avoid that radiation field and say that's something good to do, but then you can't really do that with a live donor. And so there's some technical complications that may occur later as a result. But I think that's another consideration to try to get the patient transplanted. Mike?
Just to address your first question, I do think it is challenging, but I do think with improved imaging, and I do think surgical expertise and experience has a big point here, because I think part of the margin positivity rate is there's some technique issues about going sufficiently high enough. So I do think that with high quality imaging, MRCP, and with good surgical technique in these challenging operations, the margin, it's not that common to get margin positive, probably is less than 20%. And in those cases, often those patients are not resectable. So I think experienced surgical team and high quality imaging before limits the margin positivity rate. And I think in those cases where you think the probability is high of getting margin negative resection, those patients should be offered resection.
Dr. Rocco.
Dr. Chapman, Dr. Choti, thank you for an excellent debate. And I think you put it as the most pertinent question is that the 3A, the 3B patients, these borderline resectable patients, that's the challenge. And having so few centers that actually do the transplant protocol for HILAR cholangiocarcinoma, for us being out in the Northwest, there's not that many centers that are nearby. And so the two questions I have is, one, for those patients that are deemed borderline resectable, that are explored, that unfortunately then knocks them out for transplant. So we have mutually exclusive treatment pathways here. But is that because of bile duct transection, What about patients that are explored, let's say have a lymph node harvest, but do not have their bile duct transected? Is that something that potentially would be a transplant candidate down the road? That's one question. The second question is, we talk about EUS-type biopsies, and this is always a point of confusion because from what I recall from the Mayo Clinic, they'll actually do EUS biopsies of lymph nodes that are suspicious. And obviously if they're positive, they're negative. But if they're negative, that doesn't necessarily knock them out.
Correct. So negative won't knock you out. The issue is if you biopsy the primary tumor.
I agree
and
completely.
Now this transperitoneal biopsy, the worry is tumor seeding, or transabdominal biopsies. That's really the issue. So the nodal sampling, we do that as a routine. It took us a little while with our biliary endoscopists, and they would call and say, no, tell me exactly what you want me to biopsy. And it was really, well, here's what we don't want you to biopsy. Correct. Do not biopsy the primary tumor. Right. Biopsy regional nodes, we want to know the answer.
Perfect.
I think the exploration part, and maybe Dr. Gores will comment on their approach. So in general, centers say if you've been explored, you're not a candidate for a transplant. I think the worry is that there's been tumor manipulation and that the risk of intraperitoneal or other recurrence is going to occur. Now, we've transplanted several patients that were explored by an experienced surgeon, and we were confident in what they did and what they did not do. And in fact, I think we have a patient on our list right now, explored from Seattle. That's
my patient.
We're pretty confident there was not, disruption of the tumor. I think even Mayo. I mean, Chuck just tells me there've been a patient or two or three explored. Surgeon he knew what they did, he knew what they didn't do, and they've been listed. So I think it can be done. I think the worry, though, but for sure, if you go down the pathway and make some of these steps, you're going to eliminate that patient as a transplant candidate. So the decision on the front end is pretty critical.
Of course.
But just for those that don't do this, this is not something you can operate and you determine, if the preoperative imaging looks like it was resectable, you can't see the bile ducts going up to determine whether the margin is positive. So it's not like you can now determine, this is a transplant candidate because of involvement of the secondary radicals. It's the preoperative imaging that really determines that. And when a margin is positive, it's positive. So, great.
Yeah. Thanks. So maybe I'll just address a couple of comments. We're very aggressive with live donors, I would have to say. Both Julie and Chuck certainly favor that approach. If they've been explored and it was just lymph nodes and things looked at, we're okay. But most of them have a HILAR dissection. They've got up there and
they've had tumor manipulation.
They've had tumor manipulation,
yes.
HILAR dissection. They've tried to skeletonize a vessel, realized they couldn't get it off. My question was, what's borderline resectable is kind of a moving target and unclear, particularly when it comes to vascular reconstruction. Particularly the arterial reconstruction, I think, is fraught with complications with resection, a lot of complications in those patients. So how do you two view, if you have to reconstruct the right artery on a left-sided tumor, what's your perspective on that?
Well, I think so. Dr. Gores is bringing up the point. Well, what about vascular involvement? So, historically, if you had vascular involvement, portal venous or artery, you were knocked out as a candidate for resection. I think most centers today, portal venous reconstruction, as long as it's technically feasible, centers do that more routinely. It's not a contraindication at all. We're moving towards arterial reconstruction, which had been considered an absolute contraindication, to being a relative contraindication. Now, you mentioned the right artery. I think it is feasible to reconstruct a right artery. Sometimes, if there's involvement of the bifurcation of the right artery, so the right artery extrahepatically will branch into a anterior and posterior branch, that's not feasible. So it's got to be the main trunk of the right. It definitely increases perioperative risk. but I think it's doable. And for tumors, it doesn't otherwise increase the cancer risk. So the other factors remain as important. Tumor size, vascular invasion, and nodal involvement still are going to rule the day, not whether there's vascular involvement. At least that's what I would say.
I do think, though, vascular involvement probably portends worse biology as well. So no question the risk is greater to do vascular reconstruction. Can be done, and I think, but I do think particular arterial is probably associated with also worse prognosis, and so that's another reason why we're a little less enthusiastic about doing vascular resections. I showed you the Berlin data where it's routine main portal vein resection to just get a wider margin of the lymphatics behind the portal and demonstrating good outcomes. So I think that as we get more comfortable with vascular resections, I think that may be being done more. Currently, my algorithm is only if the main portal vein is involved in a short segment, then the portal vein is resected. But we certainly don't do, I don't think anybody in this country does routine portal vein resections.
So, Mike and Bill, last question from the patient perspective. Surgeons will be probably the first touch point. What would you recommend, like some word of wisdom in regard to if there was a recommendation for a surgical intervention, shall they go seek an opinion from a referral center of a place where it might do transplant, or what kind of guidance do you give them here? Because obviously there is no guidance beside getting there to their doctor.
Yeah, I think that's a great question. You know, this is a area that patients play a big role in, surprisingly. I get more inquiries via patients probably than I get via doctors. And there's some patients and support groups that have gone on to help keep patients informed. Part of the problem is a lot of our treating physicians, treating surgeons, others don't think about transplantation. So yes, I would encourage patients who have questions to get other opinions. And sometimes it's not that you even have to travel. You can, send your questions to Dr. Gores, and he can get his advanced practice nurses to help sort through it. We do this on a regular basis. Often there's no change in recommendations, but sometimes there is. And then it at least lets you have thought through some of those considerations, especially if you're at a center that doesn't provide the full spectrum of care.
And I think it's not only applicable to, I don't think it has to be a center that has transplant. I mean, Memorial is a good example. I would hope that in patients with unresectable disease, they're referred to for options for protocols in transplant. So I think it's a matter of empowering the patient, and it's the case with many of these complex GI and other malignancies, that really empower the patient to take charge of their disease, make sure that they're informed, and certainly the foundation can play a role in that to help educate patients.
Yeah, exactly. That was the purpose, to kind of put it on the platform.
The issue with biopsy, though, often the patient doesn't. That becomes very tricky because it's very hard for the patient to say, okay, I'm pulling the plug, I'm getting a second opinion, I'm going to go wherever to a high volume center or whatever prior to a biopsy. They don't even know what's going on yet, so it's a little hard to empower a patient while the diagnostics are still going on, and that could burn a bridge, so that's a challenge.
It's fascinating, actually. The issue of the biopsy is not only from the perspective that is very critical in what you're bringing up, but even at big centers where there's quite a bit of research being done on biopsies that are already harvested, being live, like embedment, putting in a mouse and what have we. Actually, now the trend, like at Memorial and probably other sites, that we are more interested in patients who didn't get any biopsy, rather than please get your diagnosis and come to us. We are like people even with suspicions of cancer, because we think that spot is, or that stop is going to be more critical for them.
The one thing I would say, and I would extend it even beyond biopsy, before interventions are undertaken, before ERCPs are done and a stent's put up the wrong duct, the end plan needs to be carefully thought through. And this is where, as Dr. Choti says, you know, for the patient, they're not even sure of their diagnosis. It's early on. They haven't had a chance to network on this issue. And that can be difficult because sometimes the die gets cast by some of these early interventions in settings where the game plan hasn't been thought through.
Just a final comment too, though. I think that the results for any of these therapies are not that good. And as I mentioned, we need better biomarkers, so it often may necessitate some kind of tissue analysis before we know. So I think we have a challenge to have an aggressive treatment like this where you can't do a biopsy. So I would encourage other strategies, liquid biopsies and other ways to be able to really assess not only the diagnosis, but the molecular features of the tumor without burning a bridge or finding a way to transplant where patients who have had some kind of biopsy, because I think we're going to need to be biopsying these people in some way, or at least interrogating the tumor more in detailed way in some way before we offer even transplant.
100%. Thank you very much. Thank you. Well done. Thank you.